Hello friends, welcome to ProsthoHub, and today we are going to discuss the last and final session of our topic, prosthodontic rehabilitation of mandibulectomy patients. So we have discussed till the prosthetic rehabilitation of partially edentulous patients in our last session, and in this session we'll be discussing the prosthetic rehabilitation options for a completely edentulous patient. And before getting into the topic, as usual, I request every one of you to please do like and share my videos. And if you are new to this channel, my name is Dr. Jolsna, and through this channel ProsthoHub, I discuss some of the important prosthodontic topics that will be helpful for your MDS university exams. And if you have any queries or feedbacks, you can either comment below this video or you can mail me at this mail ID. So let's get started. The success of edentulous mandibular resection prosthesis is directly related to the amount of the remaining bone and soft tissues. If the tongue is broadly resected during the mandibulectomy procedure, the valuable vestibular extension regions may be obliterated after surgery. So such cases is a real challenge for the clinicians. And in these cases, the complete danger main purpose is to provide and improve aesthetics. They improve the lip and cheek contour and replace the missing teeth. And in such cases, only with implant retained and supported overlay dentures does the patient will have the opportunity for a efficient mastication. Recently, the use of advanced 3D imaging and introduction of CAD/CAM have led to successful rehabilitation of such patients to a near normal function and aesthetics. Now, let us see the factors that compromise the patient's ability to masticate with a resection complete danger. So the first factor is only half to two-thirds of the mandible will be remaining, that leads to a compromised stability, support and retention of the mandibular denture. And since many patients would have received radiation therapy either prior to or after surgery, the oral mucosa is very atrophic and fragile, that is leading to oral mucositis, predisposing to soft tissue irritation and ulceration. And then there is reduction of saliva output, that is a dry mouth after radiation therapy, which impairs retention. And we also have discussed about the angular pathway of mandibular closure in our last session, which induces lateral forces upon the dentures, which tends to dislodge them. And also the deviation of the mandible, it creates abnormal jaw relationships. The abnormal position of the mandible in relation to the maxilla will prevent the ideal placement of the denture teeth on their supporting structures. And finally, the impaired motor and sensory innervation, that is especially of the tongue, lip and cheeks, which impairs the ability of the patient to control the processes during function. So the integrated neuromuscular balance between this tongue, lip and cheek, which usually serves to stabilize a complete mandibular denture in a normal patient, is compromised in these patients. Next, let us discuss the clinical steps in the fabrication of a resection complete denture. So the first and foremost step is preliminary impression, where you have to ensure maximum tissue coverage. And for this, you can use either irreversible hydrocolloid in combination with an altered stock tray, or you can use polyvinyl siloxane. And as you can see in this picture, often the tongue closely approximates the alveolus, and so the placement of the impression material into the lingual sulcus on the non-resected side becomes difficult. In such cases, a disposable syringe is used in order to inject the impression material into these areas of difficult access prior to seating the stock tray with the impression material. And the retention of the mandible, which is achieved by close adaptation of the prosthesis with the bearing surface, and also by extending the lingual periphery of the unresected side to the maximal extent. So this will enhance the retention. And also the lingual flanges on both the resected as well as unresected side should be accurately recorded, because this will help the tongue to retain the mandibular denture in position more efficiently during function. So the status of the remaining tongue is the most important prosthodontic prognostic indicator. If the motor or sensory control of the tongue has been significantly compromised, then the prosthetic prognosis becomes extremely guarded. And also the mobility and bulk of the tongue is also important. If the patient is capable of moving his tongue in a number of directions, then he will be successful in stabilizing the mandibular denture during function. Next is about the support. So support for a mandibular prosthesis can be obtained from the buccal shelf area, the crest of the ridge, the retromolar pad, and if possible, the soft tissue bed posterior to the bony reception. But among these, the primary support area is the buccal shelf area. This is because of the lingual inclination and rotation of the mandible. And then the stability of this prosthesis is facilitated by accurately recording the contours of the lingual flanges on the unresected side. Next, the peripheral seal of the maxillary denture may be difficult to achieve in cases where there is deviation of mandible, because here the anterior border of the ramus and the coronoid process may come in close apposition to the maxillary tuberosity because of the mandibular deviation, and that happens on the non-resected side. So, in such cases, when the maxillary impression is molded, the extension of the denture around the tuberosity is compromised, and this will interfere with the peripheral seal. Coming to the centric registrations after we obtain master cast from the secondary impression. So, here record bases are constructed in the usual way, but there is a difference that the wax rim in the maxilla is widened on the unresected side towards the palatal side in order to account for the deviation of the mandible. And also the support for the upper lip should be reduced because of the deviation and retrusion of mandible. If you give the normal support for the upper lip, as in case of non-surgical patient, this will accentuate the altered maxillomandibular relationship. So you have to reduce the support for the upper lip. And usually the centric registrations are difficult to register because of the altered proprioceptive mechanisms, trismus, mandibular deviation, impaired motosensory function, muscle imbalances, etc. It will be difficult to get repeatable registrations because of these factors. And even the vertical dimension is often difficult to determine. The methods that we use usually, that is with pressure and neuromuscular determination, which are not applicable here because of the instability of record bases, the unilateral forces of occlusion, and also the altered pathway of closure. So because of these reasons, even the intraoral tracings cannot be used. If the patient has got a near normal tongue bulk, mobility and control, then evaluation with phonetics and closest speaking space are best suited methods for the determination of vertical dimension. And also the vertical dimension of occlusion should be reduced or closed as much as possible in these patients because they have got reduced tongue bulk and compromised tongue mobility. So if you restore the original vertical dimension of occlusion in these patients, it will prevent the tongue from effectively interacting with the palatal structures during speech and swallowing. So you have to reduce the vertical dimension of occlusion. And the centric occlusion registration can be obtained with either wax, plaster or other similar recording media. And here the clinician should manipulate the mandible, place it in the most advantageous position, that is within the reach of the patient. And also in patients with trismus, again the vertical dimension of occlusion has to be reduced in order to facilitate the insertion of bolus between the teeth. So these things you have to take care while recording the centric relation. Next, coming to the occlusal schemes and lateral registrations. So after the wax rims have been altered and registrations are obtained, the maxillary and mandibular casts are mounted on a suitable articulator. And because of the deviation and retrusion of the mandible, it is usually advised to place the maxillary anterior teeth lingual to the usual position and the mandibular anterior teeth labial to their normal position. And the mandibular posterior teeth should be placed in the neutral zone, that is the area where the forces of the tongue pressing outward are neutralized by the forces of the cheek and lip, that is pressing inward. And in the mandible, the posterior teeth on the unresected side is usually placed buccal to the crest of the edentulous alveolus, especially in the premolar region. This will help centering the forces of occlusion more favorably over the supporting structure, thereby enhancing the stability of the prosthesis. And this is also compatible with the existing tongue position. Whereas the posterior teeth on the resected side or the surgical side are usually placed lingual to the crest of the edentulous ridge in order to facilitate the occlusal relationship with the maxilla because of the deviation of the mandible. Next, the contour and support for the corner of the mouth and the lip on the resected side is facilitated by thickening the denture flanges below the crest of the ridge. And we know that mastication is confined exclusively to the non-defect side. And also, if you view the plane from the, if you view the profile from the frontal plane, the posterior teeth on the non-resected side will be close to the alveolar ridge, whereas posterior teeth on the surgical side may be quite far from the alveolar ridge. So there is an abnormal profile if you view from the frontal plane. And after all the mandibular teeth and maxillary anterior teeth have been arranged, ramps are developed for maxillary prosthesis in base plate wax. So we have already discussed about this guidance ramps in our first session. So these maxillary guidance ramps is effective as a guide flange for many patients, particularly when deviation is less severe. Coming to the final stage, that is the processing, delivery and follow-up. So after the trial processes have been perfected, they are processed following customary procedures, and because of the compromised denture-bearing surfaces, deviation of mandible, angular pathway of closure, abnormal jaw relationships, impaired motor and sensory innervation of the remaining tissues, and also because of the compromised tongue function, usually mastication is often difficult for these patients, and the processes should be delivered, remounted and adjusted following conventional prosthodontic guidelines, and disclosing paste must be used in identifying areas of excessive tissue displacement, and these patients should be closely monitored during the post-insertion period. Next, coming to a case presentation of hemimandibulectomy patient. So this was one of my special cases during the post-graduation time. So, a 70-year-old patient had come with a chief complaint of an ill-fitting denture and needed replacement for better chewing purpose as the food was getting accumulated on the right upper side of the cheek. So, he was a diabetic and an hypertensive patient and was under medication, and there was a history of being operated for a neck tumor since 24 years. And on examination, there was radical segmented resection on the left side of the mandible with the continuity reconstructed. So here you can see the panoramic radiograph that is showing mandibular reconstruction with fibula, free flap and reconstruction plate. And you can see here this is a class 4 Cantor and Curtis classification with the lateral bone graft and surgical reconstruction. And another thing you can appreciate here is the abnormal profile that we told during the occlusal registration that we can view in the frontal plane. So the average diameter of this fibula free flap is just 1.5 centimeter, and when used to reconstruct the edentulous mandible, the fibula height closely approximates that of an atrophic mandible, and when compared, there is a roughly two-fold height difference between the fibula and the native mandible. You can clearly appreciate it here. There is a two-fold difference between this grafted one and the native mandible. And this discrepancy is most critical when reconstructing defects in the anterior mandible. So here the fibula is placed along the inferior border of the mandible. So you can see here, this is to improve the mandibular contour, and so we may go with an elongated dental prosthesis which results in an unfavorably excessive liver arm forces. So this is the intraoral view of maxillary and mandibular arches, and here one thing you can clearly appreciate is the close approximation of the tongue on the alveolus on the non-defect side, and so here the placement of impression material into the lingual sulcus on the non-defect side is difficult. So in this case you can use a disposable syringe that is used to inject the impression material into the areas of difficult access prior to seeking the tray with impression material. Now these are the primary impressions. So we know that retention in mandible is achieved by the close adaptation of the processes with the underlying surface and also by extending the lingual periphery on the unresected side to the maximum extent. So this maximum extension on the unresected side was better achieved by using polyvinyl siloxane than the alginate. These are the secondary impressions and the master casts. Into the next step, that is the jaw relation and face bow transfer. So here the patient had a normal tongue bulk and a near normal mobility and control. So the evaluation of vertical dimension was done with phonetics and closest speaking space methods. And also we have discussed about reducing the vertical dimension in patients with a compromised tongue mobility, because this increased vertical dimension will affect the interaction of the tongue with the palatal structure, affecting speech and swallowing. But in this patient, he was comfortable using the previous dentures that was with the normal vertical dimension. So we have not reduced any vertical dimension in this case. Now here the patient's chief complaint was the accumulation of food on the right hand side of the cheek, and this may be because of the deviation of the mandible and the unstable occlusal relationship on the non-defect side. So usually following surgical resection, the remaining mandibular segment gets retruded and deviated towards the surgical site at the vertical dimension of rest, and during opening deviation increases, leading to an angular path of opening and closing. So here we tried two approaches. One was the double occlusion or the twin occlusion processes, and the other one was the maxillary palatally positioned guidance ramp. So in the first approach, two rows of teeth were arranged on the posterior side of the edentulous maxilla on the unaffected side. The first row was set according to the ridge contour, and the second one palatal to it in order to occlude with the mandibular teeth. The buccal row supported the cheek, whereas the palatal row of teeth occluded with the remaining mandibular teeth. So this provided a better and a broader occlusal table. And here semi-anatomic teeth were used and occlusal grinding was done to provide freedom in lateral movements. And here the teeth slide over one another down the incline formed by the second row of teeth and coming into a functional occlusal position. And this teeth arrangement was verified during trial, and then the denture was completed as per the conventional technique. The second approach, we used a maxillary complete denture with a palatally positioned guidance ramp. So the slope of this ramp was adjusted in such a way that the mandibular teeth first made contact with the ramp at the maximum height. Usually it is the canine or the premolars that contact the ramp first, and then it glided along the slope of the ramp into optimal occlusion. So usually guidance therapy is initiated at the earliest stage, and it aims to re-establish the correct path of closure for the remaining segment of the mandible. And this results in an appropriate, stable and functional occlusal relationship on the non-surgical side in due course of time. So here when comparing these two approaches, the double occlusion or the twin occlusion technique was found to be more effective than the other. So here the broad occlusal table developed in the maxillary arch on the non-defect side helped to position the residual fragment into correct sagittal relationship, enhancing the stability of denture and thus improving the masticatory ability. So this reduced the accumulation of food on the non-defect side. So this was the final look at the insertion stage. Coming to the last section, that is implant, retain and supported overlay denture. So we have already discussed about the factors that compromise an efficient mastication in case of resection complete denture, and it is only with implant, retained and supported overlay dentures that the patient have the hope of an efficient mastication. The osseointegrated implants enable the fabrication of well-retained and stable overlay processes, and the support that is derived from the residual denture-bearing surfaces along with retention and stability provided by the implant is much better than that of a removable processes, and it is sufficient to allow effective mastication. And we also know that one of the important factor that compromise efficient mastication in case of resection complete denture patient is the compromised tongue function. That is, these patients needs to stabilize and retain their complete denture with the tongue while using the tongue to manipulate the bolus. Whereas in case of an implant processes, the tongue is no longer required to control the denture, and it can now be used completely for control and manipulation of the bolus during mastication and swallowing. Therefore, the key to rehabilitation is the status of the tongue function following tumor resection. So when portions of the tongue are resected because of tumor, all effort should be made to restore its bulk. So if the patient is having a poor tongue function, then he has nothing to or very little to gain from an implant retain processes. And also the implant retain overlay processes are preferred over fixed processes. Let us see the reasons for this. So the main advantage of an implant retained overlay processes is that it allows for positioning of the teeth either buccal or lingual to the ridge, which is often difficult if we are designing a fixed implant retain restoration. Next, the denture flanges are available in case of an overlay processes which are necessary to provide support for the repositioned lower lip. And usually a sufficient number of implant sites may not be available to provide the number and arrangement of implant that is necessary to support a fixed restoration. Most of the patients will have only the symphysis region available for placement of implant, and usually a minimum of 2 implants can be placed. More are desirable if space allows for stability. And another important factor is the hygiene of implant surfaces, and retention bars are more easily accomplished when compared to that of a fixed restoration. This is an important factor because most of the resection patients are elderly and they may have impaired vision or poor manual dexterity. So these are the reasons why we select an overlay processes compared to that of a fixed implant processes. Next, coming to some of the important points that you have to take care while fabricating an implant overlay processes. The first one is that implant should not be placed very close to the border of the resected mandible because the bone in this region may be necrotic or poorly vascularized secondary to the previous surgical procedure. Now, if 2 implants are to be placed, then there should be at least a 15 millimeter apart space in order to accommodate the retention bar apparatus. So usually these 2 implants are splintered by using a header type bar. So this is a header type bar, and this is placed in such a way that the design is parallel to the axis of rotation of the processes when an occlusal force is applied on the normal side. So with this design of this header bar, the processes will be able to rotate freely around the bar, minimizing the torquing forces delivered to the implants. Next, the implants should be placed perpendicular to the occlusal plane and if possible within the zone of the residual attached gingiva. And also care must be taken to avoid lingual inclination because there is a chance that these implants may exit through the mobile tissues of the floor of the mouth, and so the prognosis for a lingually inclined implant is poor and usually it requires burying them beneath the mucosa. And also during the second stage surgery, when the implants are uncovered, care must be taken to thin the mucosa around the implants, and healing abutments are inserted, and within 1 month definitive processes is fabricated. So once the healing abutments are inserted, when the peri-implant tissues are well healed, border molded impressions are made, center relation records are obtained, and then the teeth setting, the trial dangers are inserted, records verified, aesthetics are refined as necessary, and then a template is made which is used to fabricate the retention bar apparatus. Then the bar is cast and verified orally, and then the processes is completed using conventional laboratory methods. And these patients should be followed up every 3 months to ensure compliance with the prescribed oral hygiene measures. So here you can see a case where they have inserted a CAD/CAM milled bar attachment apparatus and then verified the position using a radiograph, and then the bite registration done, and this bar retained implant overdenture has been fabricated. Finally, concluding this session, so patients who have undergone hemimandibulectomy or segmental resection of mandible are faced with considerable challenges which include impaired speech articulation, difficulty in swallowing, mastication, altered mandibular movements, compromised control of salivary secretions, severe cosmetic disfigurement, etc. And restoring the continuity of the mandible with osseous and soft tissue free flaps is a recommended philosophy, and it aims at maintaining the balance and symmetry of the mandibular function. And recently we have seen the use of advanced 3D imaging, microvascular graft, and also significant advances in prosthodontic techniques such as CAD/CAM and also laser assembled processes have allowed these patients to be rehabilitated to a near normal function and aesthetics. So the main idea behind the treatment of hemimandibulectomy patient is that importance should not be given on what is lost in the removal of disease, but rather taking complete advantage of the remaining structures. Now these are my references. Thank you all for watching this session, and I request every one of you to please do like and share my videos. And if you're new to this channel Hub, please do subscribe and support me. If you have any queries or feedbacks, you can either comment below this video or you can mail to this mail ID. So it's a bye from Hub until our next session with a new topic. Thank you all.